Hi, I am Dr. Vishwanath, and today I want to discuss regarding World Heart Federation guidelines for the echocardiographic diagnosis of rheumatic heart disease, which is published in 2023. This is a published article of 2023 by World Heart Federation. What are the various endorsements for these guidelines are American Heart Association, Australian Heart Foundation, Inter-American Society of Cardiology, Pan-African Society of Cardiology, and Australian guidelines for the prevention and diagnosis and management of acute rheumatic fever and rheumatic heart disease. So, what are the new features which are mentioned in 2023 guidelines? Let us see. There are two sets of echocardiographic criteria. One is screening criteria and another one is confirmatory criteria. Screening criteria is principally for non-experts and confirmatory criteria is for experts. See, whenever the non-expert is having suspicion of rheumatic heart disease, there is a separate criteria. But for experts, there is another criteria for rheumatic heart disease. And there is a classification of rheumatic heart disease into stage A, B, C, D based on the progression to more advanced valvular heart diseases. And the previous mentioned guidelines having borderline, definite and latent rheumatic heart disease are no longer recommended. And a new feature in these guidelines is weight-based measurement of valvular regurgitant jet length. Recommendation for the management of for the early stages of rheumatic heart disease are also mentioned. Let us see. Previously, 2012 guidelines that mentioned latent rheumatic heart disease, borderline rheumatic heart disease, and definite rheumatic heart disease, and these are no longer recommended. First, we see the approach to rheumatic heart disease screening. First, take the history of acute rheumatic fever and rheumatic heart disease and screen the patient. If for positive screen test, there should be at least one of the following, like minimum mitral regurgitant jet length, minimum mitral regurgitation jet length, 1.5 centimeters for weight less than 30 kgs and 2 centimeters if weight more than 30 kgs, and at least in one view mitral regurgitation should be there, and then at least two consecutive frames. And for aortic regurgitation, any AR jet length, there is no specific centimeters mentioned for aortic regurgitation, and at least one view and at least two consecutive frames is same for aortic regurgitation as mitral regurgitation. Both having at least one view and two consecutive frames, but lengths are different for mitral regurgitation and aortic regurgitation, or restricted mitral valve leaflet motion or reduced opening. If any of the following is present in a patient, then it is a positive screen and send the patient to confirmatory echocardiography for expert opinion. But if the screening test is directly done by the expert, then you can combine the screening and the confirmatory echocardiography in the same time. So, what are the various confirmatory criteria? Criteria for pathological MR. It requires all of the following, like observed in two views, and minimum mitral regurgitation jet length should be 1.5 centimeters if less than 30 kgs and 2 centimeters if more than 30 kgs, and observed in at least one view. See, the regurgitation should be present in two views, and the lengths, specific lengths should be at least in one view is enough, and velocity should be at least 3 meters per second, and pan-systolic jet should be there. For aortic regurgitation, to name it as a pathological AR requires all, like observed in two views, and velocity should be 3 meters per second, and pan diastolic jet. See, for pathological MR and pathological AR, it should be observed in two views and it should be 3 meters per second. Same. For mitral regurgitation, it is pan-systolic. For aortic regurgitation, it pan diastolic. And what are the rheumatic heart disease morphological criteria? Mitral valve anterior leaflet thickening and or mitral valve caudal thickening, mitral valve leaflet restriction and or excessive anterior leaflet tip motion, and aortic valve thickening, prolapse and restricted leaflet motion. All these are the morphological criteria. Now next step, if these are present, the next step is staging. See, if the patient is having already moderate to severe MR, moderate to severe AR, mitral stenosis, aortic stenosis, pulmonary hypertension, LV dysfunction, then you can directly label it as patient as stage C or stage D. If they are not there, then if the patient is having pathological MR or pathological AR, any one MR or AR with no abnormal morphological features like thickening, leaflet restriction, or prolapse and a restricted leaflet motion for mitral valve and aortic valve, if there is no such morphological criteria, then you can label the patient as stage A. But if the patient is having both pathological MR and both pathological AR, then you can label it as stage B. If the patient is having pathological MR or AR, any one, but with at least one morphological criteria, if the age is less than 20 years, or pathological MR or AR with at least two morphological criteria, if age is more than 20 years, then you can label it as stage B. So after labeling as stage A, B, C, D, what is the initial care we have to do? Initial care is, first of all, enroll the patient in rheumatic heart disease registry and start secondary antibiotic prophylaxis in stage A. It's a class 2A recommendation, not class 1, and review after 1 to 2 years. It's class 1 recommendation. So if you stage as a stage A, you have to review every 1 or 2 years. That is mandatory. And cessation of secondary antibiotic prophylaxis in stage A based on echocardiography, if normal after 1 to 2 years, is class 2B recommendation. And stage B, you have to enroll in rheumatic heart disease registry and start secondary antibiotic prophylaxis. It's a class 1 recommendation. If the patient is having stage B, like pathological MR and AR both are present, or MR or AR with at least 1 or 2 morphological criteria, if the age is less than 20 years and more than 20 years respectively, then you have to start secondary antibiotic prophylaxis, and this class 1 recommendation. And duration of prophylaxis is based on the local guidelines or WHO guidelines. For stage C and D, you have to register the thing in rheumatic heart disease registry and start secondary antibiotic prophylaxis, class 1 recommendation, and duration is based on local guidelines or WHO guidelines. What is the difference between stage C and D is, if the patient is high risk of developing clinical complications, stage C, but if the patient is already having clinical complications, then you can stage it as stage D. We can have mild valvular regurgitation in other diseases like mitral valvular prolapse and bicuspid aortic valve. So before labeling it as rheumatic heart disease, you should exclude mitral valve prolapse and bicuspid aortic valve. What we have to do if the weights are not there? Then you can use the cutoff of age as less than 10 years and more than you can use. The regurgitant jet length should be measured from the tip of the vena contractor to the last pixel of regurgitant color. To measure the length of the regurgitant jet, you have to measure from tip to tip of the color. Given the difficulty in aligning the spectral Doppler, especially for eccentric jet, to label it as a pansystolic or diastolic, it's very difficult. So in such times, you have to use the color Doppler, and you should see with your eyes whether it is a pansystolic or diastolic, whether it is throughout the systole or not, or throughout the diastole or not. You have to see. And two-dimensional evidence of reduced mitral valve orifice area, 2D orifice area, if it is reduced, there is that is adequate when spectral Doppler is not available. These are already discussed, like confirmatory. What are the various confirmatory morphological features of rheumatic heart disease? Like valve thickening, AML thickening, anterior leaflet thickening, or caudal thickening. Any one is if is enough. And valve mobility, restricted of anterior leaflet or posterior leaflet during diastole, or excessive anterior leaflet tip motion during systole. For aortic valve, cusp thickening, prolapse, restricted cusp motion, and coaptation defect in diastole. See, for anterior mitral valve leaflet thickness, it's very important, should be measured during diastole at full excursion. Okay, at full excursion of the leaflet, we have to measure. So measurement should be taken at the thickest portion of the leaflet, like thickening, focal thickening, beading, the nodularity. Ideally, the measurement should be performed on a frame with maximal separation of cauda from the leaflet tissue. Cauda should be separated from the leaflet, at least during whatever the frame you are taking during 2D echo, that should be maximal separation between the cardia and leaflet. Otherwise, you will overestimate the thickness, and you can overestimate thickness and over the diagnose the rheumatic heart disease. Abnormal thickening of the a anterior mitral leaflet thickening is age specific and defined as 3 mm, more than 3 mm if less than 20 years, more than 4 mm if less than 40, more than 20, and more than 5 mm if more than 40 years. 3, 4, 5 mm. Caudal thickening might range from individual cauda tendinae to multiple cauda tendinae fusion and calcification. The structure of papillary muscle, cauda tendinae, and margins of the leaflets is not clearly distinguishable when the disease is progressed. When the disease is progressed, then you are it is very difficult to differentiate papillary muscles, cauda tendinae, and margins of the leaflet in the 2D echocardiography as the disease is progressed because of thickening and disease progression and fusion of the cardiac calcifications. It is very difficult to distinguish, and assessment is always a subjective. However, caudal thickening is attributable to the fusion of two or more cardia and is seen as echo bright structures near to the tip of the leaflet insertions. Caudal thickening is typically associated with other morphological features like restriction, thickening of the leaflets, all calcification, other features will be there. So restricted leaflet motion of leaflets, whether anterior or posterior, is usually due to caudal shortening. Chordae will be shortened due to the disease and fusion of the commissure, commissural fusion between the AML and PML, or leaflet thickening. But whereas excessive leaflet motion is due to the elongation of the primary chordae will be there, and those elongation causes the leaflet to move more than the usual movement, and is defined as displacement of tip or edge of an involved leaflet towards the left atrium, resulting in an abnormal coaptation, and it always leads to abnormal coaptation always leads to regurgitation of the respective valve. Excessive leaflet tip motion doesn't need to be made the standard echocardiographic definition of mitral valve prolapse like 2 mm. So, given that they refers to different disease process, mitral valve prolapse excessive motion of the leaflet disease process is entirely different, and excessive motion of the leaflet tip here in rheumatic heart disease is entirely different. And this is characteristically applies to only those aged less than 35 years. In parasternal short axis view, right coronary cusp and non-coronary cusp closure line is present as echogenic, like thickened, in healthy individuals also, which should be considered as normal. Don't take it as an abnormal. And these are the staging of rheumatic heart disease detected by echocardiography. Stage A, minimal echocardiographic criteria for rheumatic heart disease, applies to only those with the age less than 40 years old and clinically at risk, and echocardiography features like mild MR or AR without the morphological features. And stage B, mild rheumatic heart disease, either the patient is having MR and AR, or MR with one MR or AR with any one morphological features if less than 20 years, and if more than 20 years, two morphological features will be there with either MR or AR. And stage C, as you know, the patient is at clinical risk of developing the complications, whereas stage D is the patient is already having clinical complications like heart failure, arrhythmia, stroke, infective endocarditis, or history of cardiac surgery. Anyone will be there to name it as a stage D. Okay, thank you for watching.